2 teenagers were shot and killed in a park in Philadelphia last night. A 48-year-old man was fatally shot in a deli in New York City. In Portland, Oregon, a man was shot at the beach. And in Baltimore, Maryland, 2 people were killed in 2 separate shootings. Those are only some of the fatal shootings picked up yesterday by the Gun Violence Archive, a nonprofit that tracks shootings in the U.S. In the grand scheme of things, they are just a drop in the bucket. On an average day in the U.S., nearly 100 people are killed by guns, according to CDC data, including murders, suicides, and people shot by law enforcement. And for the youngest among us, children up to 19 years old, gun violence is the second leading cause of death behind only car accidents. It's a problem so big you would think it would be a top priority for the U.S. government and the subject of study after study by federal researchers. You'd think that, but you would be wrong. Until language in something called the Dickey Amendment was clarified in March, the CDC was effectively banned from using any of their funding toward gun violence research. And laws are still on the books that prevent the Bureau of Alcohol, Tobacco, Firearms and Explosives from releasing data they collect for its national database of guns used in crime. And even with the authority to conduct research, the funding still isn't there. So it's been up to private organizations and researchers like my next guests to fill the void. Dr. Chana Sacks and Dr. Peter Masiakos are the founders of a new Center for Gun Violence Prevention at Mass General Hospital. Thank you both for being here.
Thanks for having us.
Can I get you to start off by talking about the personal resonance that this issue has for you, because you both feel invested in it emotionally as well as clinically?
Yeah, I think Peter and I are like most people in this country, where it's becoming harder and harder to not be affected by this issue. And I was a medical student at the University of Chicago, and you can't live on the south side of Chicago and train there without having some sense of this issue. But I was a second-year resident at Mass General 6 years ago when my cousin Mark Barden, when his 7-year-old son Daniel was murdered at Sandy Hook Elementary School. And from that, I really witnessed the worst pain I had ever seen up front. There's this picture. Some of the worst pain that I'd ever seen up front. And also after that, I witnessed the response to it from my family, from all of us together, and from my cousin Mark, which was wasn't even a choice, it felt like, but just what had to be, that if he could be part of making sure that no other family had to go through what he was enduring every single day, that he was going to do that, and I'm following his lead.
Peter, how about
and for me, I'm a pediatric trauma surgeon at MGH, and I take care of the kids that have been shot. I started my training at Boston City Hospital in the 90s, and that was a peak of gun violence in Massachusetts. And the worst part of my job was walking to the room that I told the parents of the dead children that their child died, and I couldn't do anything about it. And as you alluded to at the beginning, in the introduction, you talk about the deaths in Chicago, the deaths in Philadelphia, the deaths in New York, and it's far beyond that. The scope of this problem is more than just the deaths. I take care of the injured, and we're really getting good at it as surgeons. We're being trained to take care of the injuries that they see in battlefields around the world, and we're good at fixing the holes, but the problem transcends the holes. It goes beyond the holes. And I think that the tipping point was reached when we were challenged to stay in our lane as physicians. And it's precisely that we are in our lane that we're able to comment about these things.
When were you challenged to stay in your lane as physicians?
In November of last year, when the NRA posted a response to the idea that physicians shouldn't be talking about gun violence as an issue.
It occurred to me as I was getting ready to talk with the two of you that, on the one hand, I always thought that it was ridiculous that the CDC couldn't dive into this stuff and go public with its findings and advocate based on its findings. But that being said, I have absolutely no idea what the big unanswered questions are when it comes to the way gun violence works. So can you describe for me some of the things that we still don't know the answers to that you'll be delving into at the center?
Absolutely, and it's that area is vast. The CDC isn't tracking non-fatal injuries, for example. So we have good data, and you just went through a lot of those numbers on the number of gun deaths every year, every day, every year. But in terms of the number of people who are shot and injured and are now living in our communities and are our lifelong patients, we have no national tracking in any organized way of who's being injured and what that experience is. So we're doing a lot of work now to try to identify and track these non-fatal injuries and really understand the experience. And that's one thing. The second is when patients come in and suffer some form of penetrating trauma, assault, or a gunshot that they survive, or a knife wound. We need to better understand what services, how do we wrap around patients in those vulnerable moments as they transition back into the community and really break these cycles of retaliatory violence that we see.
And we have to also understand how to ask the questions as physicians. And we haven't been doing it. And let's take suicide, for example. As a medical student, I was asked to ask the patient about a plan. And we were taught about asking about a plan when we know that many suicides are impulsive. And the act is done within 10 minutes of the thought of suicide. And I think if you look at this problem as we look at every other public health problem, there are things that we have to learn about in communicating with our patients to understand who's at risk, what the social determinants of these traumas are in the neighborhoods that are most affected by it, and the misconception that we see the sensational shootings that everybody's focused on in the news, when reality is that suicide is the #1 cause of death because of gunshot in the United States. And the consequences of that with respect to the families and the victims of the peripheral victims, the members of the neighborhood that can't walk out of their homes to go to a school bus or to attend a program, an after-school program. And these are the things, these are the social issues that physicians are seeing in the clinic that we may have an impact on. And to depoliticize this is the most important thing for us, is to identify a place where we can actually make an impact, like we've done for smoking, like we've done for HIV. And I think that's the drive behind what we've decided to do at Mass General.
Again, when I was getting ready to chat with you, I came across one report which suggested that not every physician shares your take on gun violence as being at its core, maybe I shouldn't say at its core, but being, among other things, a public health issue. Am I right about that there's some division of opinion, or am I incorrect?
You know, I think it's so about how you frame the issue. And, you know, Peter and I, we are not anti-guns, we're anti-bullet holes in our patients. And I think when framed that
Seems
way,
reasonable.
I think it's framed that way, which is, that's not a spin, that's genuinely what we believe and what we're working on. I think every healthcare professional aligns and could get behind that mission. And I think there's always going to be nuance in, you know, whether it comes to nutrition counseling, anything else, whether, you know, what physicians see as exactly their role and how to get involved, then that nuance is okay, and we're happy to lean into it and have those really interesting conversations as we go.
And the debates are welcomed. As a trauma surgeon, I'm essentially trying to put myself out of business. So any injury prevention thought for me is to prevent the injuries from coming to the emergency department for me to take care of, and the cost is exorbitant. So we can divert the funds that we save to other reasonable programs that hospitals need.
Also, it's just becoming so hard to not think about gun violence. And I think we've noticed that across the U.S., in our communities at home, but in our hospital community as well. You know, when Peter and I started working on this issue together, there were about 4 of us in a room that used to meet, and then it became 8 of us, and then it was 12 of us, and now it's sort of standing room only in our regular meetings. And last year during the March for Our Lives, we just sort of had a photo shoot outside of the hospital and took a picture, and 500 people from all across the hospital came streaming out to just join us. And I think people. No one, I think, can look at this problem right now and say doing nothing is an acceptable response. I'm
glad you brought up March for Our Lives. I was wondering if it's going to be tricky for you guys to decide how to draw a line between research and advocacy for your patients, trying to keep them from getting bullet holes in them, on the one hand, and then being seen as overtly political when it comes to this issue. And in a way, when you talk about what you're trying to prevent, it seems absurd to frame it as a political issue. But as you know, it's intensely political. So is that going to be a tricky balance for you to strike?
I think that we are committed to staying grounded in the evidence. And we will advocate when the evidence base is strong for something in particular. But that really is our focus, is really building this evidence base, following those data wherever they lead us, really with an open mind. And really working with people in the community who have been doing this work for decades on the front lines, and asking people in the community what they need and following their lead and how we can work together. And I really think that is our space.
And all of the things we do are political to some degree. Everything that we've talked about tonight has little political snippets of political balances, right? But you know, HIV, when it first happened to hit the news media, and in
even
fact
nutrition,
all of nutrition, right? Exactly. So I think to limit that is not sensical.
Point taken.
Yeah.
We got to leave it there. Peter Masiakos, Chana Sacks, thank you both for being here, and good luck.
Thank
Thanks
you.
for having us.
Thanks.